Good afternoon, everyone. This is Susie. I'm a nurse practitioner at the IBD Center at Cedars, Sinai. Today, we're going to talk about extraintestinal manifestation in relation to IBD. IBD is a systemic disease which manifests not only in the gut and GI tract, but also an extra manifestation of organs in many patients. The quality of life for patients with IBD can be substantially affected by this extraintestinal manifestation. Therefore, it is very important to have a knowledge of the prevalence and pathophysiology and clinical presentation of EIMs in order to choose a right therapy and to treat, to cover all aspects of IBD. Okay, so the objectives that we have is understand and pathophysiology of EIMs, recognize common EIMs and IBD by organs, and understand relationship between EIMs and IBD activity, where lastly we'll discuss effective treatment options. Pathophysiology EIMs is very complex and multifactorial, and also is not fully understood, even though we have many EIMs related to IBD. Key aspects of EIMs are similar to EIM pathophysiology and genetic predisposition of IBD. Genetic predisposition is a considerable amount of overlap between genetic risk foci for EIM and IBD. It is extension of immune-mediated response from the inflamed gut to the rest of organs. Environmental factors such as smoking and changes in the gut microbiome can substantially impact on EIM. The inflammation always begins in the GI tract, and this dysregulated immune system attacks various parts of body. It is very common in IBD, and about 50% of patients with IBD will develop at least one EIM in their lifetime. 31% Crohn's disease is impacted, 43% of ulcerative colitis is being impacted. And they are more prevalent in women than men, and having one EIM increases susceptibility into additional EIM. The EIM is categorized into three sections. The first one, EIM, is directly related to intestinal inflammation. Peripheral arthritis, oral ulcer, episcleritis, and erythema nodosum are some examples of those type, and often improves with the treatment of IBD itself, because the gut inflammation and an EIM inflammation is clearly related. The EIM not related, directly not related to intestinal manifestation is a second category, which is ankylosing spondylitis or uveitis. As you can tell, it may reflect an individual's susceptibility to related autoimmune disorders, and it may and may not get improved with the treatment of gut inflammation. EIMs, lastly, is unclear relationship with the pyoderma gangrenosum. It's a skin EIM, and primary sclerosing cholangitis, which is a hepatic EIM. It may have other factors impacting this EIM. The EIM is usually categorized by organs, and you can see the one in the greens is the most frequent, and the blues are usually, it's a rare manifestation. Uveitis, axial arthritis, primary sclerosing cholangitis, erythema nodosum, pyoderma gangrenosum, and Apple's ulcer, altered hepatic pancreatic function, and peripheral arthritis. And thrombotic embolism is a common one, but one in the blue can be happening, but it's in the rare occasions. In this presentation, I'm going to talk about musculoskeletal EIM, ocular EIM, dermatology EIM and hepatic EIM. First, musculoskeletal EIM is most common EIMs occurs in about 40% of IBD patients. And particular symptoms may occur even before the diagnosis of IBD and continues with IBD after diagnosis. IBD and spondylitis are linked through a shared genetic gene, which is HLA-B27 gene, which has a strong relationship with autoimmune disease. The strongest genetic association shown here is a NOD2 and CARD15 genes. And it also shares similar cytokine immune pathways, the TNF-alpha and IL-23. I'll go back to that later because it's impacting the changes and then which medication we can choose for each EIMs. Muscular manifestation is divided into two categories based on the location of arthritis. As you can see, axial spondyloarthritis, it usually involves about 1 to 6%, which is less common than peripheral spondyloarthritis. It's affecting spine and sacroiliac joint. It's a common sacroiliitis, ankylosing spondylitis that we see in this category, and dominant axial symptoms are back pain and morning stiffness on the spine. Interestingly, patients will say, unlike osteoarthritic patient, they have more pain in the evening. Patient with axial spondyloarthritis always said that it's very stiff in the morning and it gets better as times go by. A peripheral spondyloarthritis, it affects about 10 to 20% of IBD patients. It's usually symmetrical arthritis involving the small joints, fingers and toes. Peripheral spondyloarthritis are further categorized into type 1 and type 2. And type 1 is usually the periarticular arthritis that involve the fewer than 5 joints, and acute asymmetrical arthritis usually involves the pain and swelling. And mostly large joints in the lower extremities is common in knee joints. And clearly correlate with IBD and usually self-limiting if IBD is treated properly. Whereas type 2, which involves more than 5 joints, it has a symmetrical arthritis, persists for months and years, and it is independent of the IBD activity in the gut. Then, what kind of treatment and medication do we use for musculoskeletal manifestation? First line medication is the anti-TNF. If you remember that arthritic pathways involve TNF-alpha. So the first line we use is anti-TNF. And for peripheral spondyloarthritis, we sometimes use sulfasalazine and ulcerative colitis, or methotrexate for Crohn's disease. But it is less effective if the patient has an axial spondyloarthritis. Use the ustekinumab, which is a monoclonal antibody. It's the targeting subunit P4 of IL-12 and 23. This is shown to be effective, especially for peripheral spondyloarthritis. Vedolizumab has mixed results, and JAK inhibitor has been effectively used for peripheral spondyloarthritis. And as always, short-term management. The patient who has a severe joint pain, we need to use steroids to calm it down. And some occasions, if a patient is in full remission, NSAID, which is COX-2, in patient in remission can be used up to 2 weeks. As you can see, the inflammatory bowel disease and EIM sometimes is related and sometimes it's not related. That's why it is important to work with rheumatologists to target 2 areas at the same time. Next, EIM, I'm going to discuss is a skin manifestation. It occurs about 15% of the patients, and diagnosis of cutaneous EIM is truly based on clinical pictures and characteristics of rash or lesions. There are 4 different categories in skin manifestation. The first is reactive. to share common immune pathophysiology, such as erythema nodosum, ioderma gangrenosum, sweet syndrome, and oral lesions like a cankerosoma. Usually, it has clear relationship between the gut inflammation and the EIM. Specific categories include share same histopathologic features, such as metastatic Crohn's disease. It shares granulomatous lesion in their path, and metastatic Crohn's disease can happen anywhere in the body, and sometimes it happens in the vaginal area. So you have to be very cognizant about metastatic Crohn's disease. Associated categories, it has a feature do not share any pathophysiology or histopathology features, such as the hidradenitis suppurativa. And the last category is the complications from IBD, as a consequences of IBD or reaction to IBD treatment, such as anti-TNF, thiopurines, sulfasalazine, or methotrexate. I'm sure you've seen many rashes and the psoriatic lesions and all that from anti-TNF treatment. The first skin manifestation I'm going to discuss is the erythema nodosum. As you can see in the picture, it looks like a bruise in your legs, and the most common type of skin manifestation, it is tender to touch, it's red, and sometimes it's a raised and the subcutaneous nodule. The usual common place happening is the extensor surfaces in the lower leg and the shin area. More prevalent in female than male and associated with the active disease. So when you treat gut inflammation, it usually is the signs. Next, skin manifestation is a pyoderma gangrenosum. As you can see, it's not the lesion, it is a lesion, open lesions. And it rises at the site of trauma. It's a pathogen. So even the middle trauma kind of has exacerbated immune pathophysiology, like an immune response. So it's constantly inflamed. Prevalence is 0.4 to 2.6%. It's much less. And again, usual spot is lower limbs, but it's not uncommon to see peristomal area hyoderma gangrenosum. We had a patient who has a very severe hyoderma gangrenosum in peristomal area, so we had to move around her stoma because of a pyoderma. And it looks erythematous and pustules and nodules and deep wound ulcers. And because it's rise from the site of trauma, skin biopsy is contraindicated. And because of the lesion is open and fluent and deep, the secondary infection is very common, and we have to treat them separate concurrently. Next skin manifestation is sweet syndrome, which is associated with fever, painful erythema, plaques, and nodule. It happens any part of the body and often associated with other EIMs, such as a musculoskeletal or ocular EIM. And often attacks a middle-aged female, occurs equally in UC and CD, and more common in patients with the colonic involvement in their IBD. Next one is an oral lesion, and I'm sure you've seen many canker sores and Apple's ulcers, and it's a painful, and it's around, and it's associated with the Crohn's disease activity. The last one is a hidradenitis suppurativa. It's more common in Crohn's disease, and it's a chronic skin condition, involves the IL-17A and IL-17F pathway. An IBD patient with a Crohn's disease, hidradenitis, tend to have a more aggressive fistulizing Crohn's disease phenotype. It is painful, pus-filled lumps, and follicular occlusions. Also, it is a secondary, we have to be cognizant about secondary infection in this type of patients, lesion. And areas where the skin rubs most is armpits and groin is very common, and then under the breast. And the treatment is anti-TNF, but I wanted to make sure that anti-IL-17 is also effective, but it has a potential risk of inducing or exacerbation of IBD. We had a patient who had a HS, and then they were treated with secukinumab, which is excuse me, brand name is Cosentyx, and then she developed IBD after she's been treated with Cosentyx. So we have to be aware of what medication we can choose for this type of a skin manifestation. Then, what kind of treatment and medication is available for skin EIM? Erythropoietin first line medication is usually systemic corticosteroid, and secondary line is immunosuppression, azathioprine or methotrexate. A biologic, usually we use anti-TNF, it's most effective, and vedolizumab, there is some data, but it's not strong. And pyoderma, its initial approach is systemic corticosteroid or cyclosporin for acute response. If you are using cyclosporin, the patient has to be admitted to the hospital because it's given in intravenously. And then once it's calmed down and we transition to oral cyclosporin and eventually transition to anti-TNF. Biologic and highly effective is anti-TNF. And sometimes we use ustekinumab for a patient who doesn't respond to anti-TNF as a first-line medication. And vedolizumab, as I said, there is some efficacy, but it's not clear. And JAK inhibitors, which blocks IL-6, interferon gamma, IL-12, 23, has been shown some effectiveness in tofacitinib, which is a brand name is Xeljanz, for pyoderma gangrenosum, upadacitinib, which is Rinvoq, brand name is Rinvoq for psoriasis and atopic dermatitis. Next manifestation I'm going to talk about is ocular manifestation. It's less frequent than any other EIMs. The prevalence of ocular EIM with IBD patients is about 2 to 7%. And occurrence is more with Crohn's than UC. And it is clinically important because of the seriousness of the visual impairment if not diagnosed or treated properly. I'm going to talk about 3 different types of ocular manifestation. The first one is episcleritis. I'm sure you've seen a patient who's flaring, has red eyes, and most common, and irritated eyes, and it has a mild discomfort, and it doesn't have any impact on visual acuity. Whereas scleritis is less common, but it causes more severe pain and severe presentation. It's deep eye pain and potential for vision loss. It may or may not correlate with IBD activity, and photophobia and extra tearing is a common presentation. And uveitis, which is the most severe case of EIM, is edema of the middle layers of eye, and photophobia, vision changes. Then you have an urgent referral to ophthalmologist. It is independent of IBD inflammation in the gut, and it would usually treated with topical and systemic steroids. But if you see scleritis and uveitis, which patient present with the moderate to severe eye pain, there is an emergency urgent referral to ophthalmologist. Then what kind of treatment and medications are available for ocular and EIM? Scleritis and episcleritis usually use topical and oral NSAIDs used with caution and immunosuppression, and biologics usually is the most effective medication treat with. And uveitis treatment to be started within 24 hours by ophthalmologist. Usually topical or oral steroid and dilating drops can be administered to relax muscle of the iris, so it will decrease the vision changes and vision loss. And biologic agent, which is anti-TNF, is the most effective, and surgery is the next effective treatment. The next one is a hepatobiliary manifestation. It's up to 50% of a patient with IBD are affected by hepatobiliary EIM during their disease. It has a wide range of hepatobiliary condition in IBD, ranging from transient liver enzyme elevation abnormality to life-threatening like liver failure caused by cirrhosis. Typical diagnostic workups is a combination of a serological and blood work and radiology and lab investigation. We usually use ERCP or MRCP, and on occasion, liver biopsy is performed. And the type of hepatobiliary manifestation include primary sclerosing cholangitis, fatty liver, adenomatous hepatitis, autoimmune hepatitis, pancreatitis, cholestasis, gallstone formation, and liver injury. PSC is most common, which is a primary sclerosing cholangitis. It's most common EIM associated with the IBD, but the pathophysiology is not well understood. And inflammation and fibrosis of the biliary system or the chronic cholestatic disease. 75 to 80% of the PSC patients are diagnosed with IBD, and multifactorial local bile duct strictures and segment dilation is a typical features and characteristic you will see in ERCP or MRCP. PSC can precede diagnosis of IBD. So some patients are even diagnosed with PSC several years even after procolectomy due to ulcerative colitis. More common with UC than Crohn's disease. Usually diagnostic tests involve liver enzyme, imaging scans as I mentioned, MRCP and ARCP, and the liver biopsy. The natural course of the PSC is independent of IBD activity of the gut. And unfortunately, there's no effective treatments, and a PSC patient go on developing cirrhosis, then they require a liver transplant. It has a significant risk of cholangiocarcinoma, and also it has an independent risk factor for development of colorectal dysplasia, which requires an annual colonic surveillance, and also strong association of a colorectal carcinoma in a patient with IBD. It's reported about tenfold increased risk of a colorectal carcinoma with a patient with the PSC. Then what kind of treatment and medication is available? And the liver enzyme, like ursodeoxycholic acid, which the brand name is Ulsodiol, can be used to treat the liver enzyme improvement, but there's no real changes in PSC course. And vancomycin has been shown potential treatment option, but it is off-label use, and it's not the standard treatment. Anti-TNF, vedolizumab, and ustekinumab are used, but biologic agent has a very limited efficacy. The most effective way is endoscopy, retrograde cholangiography, which is the ERCP, with stent placement and dilation of the duct. And if there is no effective treatment, the liver transplant is the next effective treatment for this type of EIM. So we talked a lot about EIM in the last 25 minutes or so. And then I would like to emphasize the next 3 slides, that this is more like a take-home message. We need to understand the relationship between EIM activity and intestinal activity to choose the best option for the medication for the patient to take care of the both entity. When you look at it, parallel course of IBD, peripheral arthropathy, erythema nodosa, Sweet syndrome, oral presentation, oral ulcers, and episcleritis, that it's important to treat inflammatory bowel disease in the gut, then eventually EIM will improve. But separate, which is axial arthropathy, which is sacral iliitis, ankylosing spondylitis, or peripheral arthropathy type 2, which has more than 5 joints involved, then it is kind of important to involve a rheumatologist to treat both, because it may not be improved even though your gut inflammation is. And lastly, it may or may not Improve is pyoderma gangrenosum, uveitis, and primary sclerosing cholangitis. In those cases, it is very important to involve ophthalmologists, rheumatologists, and your hepatologist. And then snapshot of the EIM and the treatment, you probably noticed that I've been talking about anti-TNF, anti-TNF, and TNF. So when you look at spondyloarthritis and arthritis, anti-TNF is the most effective medication to choose. And the JAK inhibitor has been showing some improvement, and anti-IL-12 and 23, especially for spondylitis, because it shares the same pathophysiology and immune pathway. And pyoderma gangrenosum and erythema nodosum, so skin manifestation also, anti-TNF is the most effective medication to choose. And then JAK inhibitor has been shown some improvement, but Vito, there's some information, but it's like unclear. And anti-TNF definitely for uveitis. This is a conclusion. EIM, extraintestinal manifestation screening, should be an integral part of the assessment process. It should be a part of your everyday assessment note. It should be a new note, and then it should be in your assessment tool. And it's early and accurate diagnosis that's crucial to prevent morbidity and further mortality. It is important to recognize the connection between activity of the inflammatory bowel disease of the gut and then EIMs for the best treatment option. EIM can be even more debilitating than the inflammatory bowel disease patient. I've seen many patients who have Parkinson disease and multiple pyoderma gangrenosum, also requiring multiple hospitalization, and also like a joint pain who is so debilitating they have to be on disability. The effective management of IBD, along with a careful monitoring EIM, leads to improving EIM symptoms. And lastly, the multidisciplinary approach always is crucial for optimizing patients' outcome. Do you have any